Hopefully some of you saw our podcast. The same panel here, we did a podcast on the same subject last month. And so we actually had a chance to make a few changes and make it better. So hopefully you'll enjoy it. The title of our presentation is Using Value-Based Enterprise to Integrate Specialists with Primary Care. Now, as most of you who are watching today know, there has been some substantial progress over the last, 15 years in moving value-based care in the primary care sector. However, significantly less headway has occurred with specialty care. And clearly, the whole concept of accountable care organizations, when it was originally espoused back in, 2006, was the idea of putting together all areas of healthcare as a team. And that has been especially challenging to do. But to be sustainable and to be able to move it to the next level, you have to basically connect at least, primary care and specialty care. Our distinguished panel today is going to talk about how you can potentially do that, and we'll deliver some ideas, particularly through the area of a value-based enterprise, which is something that has been out there now, ability to use it for almost 4 years. But it has not been used as much as we think it should. And we'll be telling you how to basically work in that direction as well. I'm the moderator of the panel. My name is Mike Siegel, and I'm a partner with Nelson Mullins and the co-chair of the Healthcare Practice Group. We do have 4 distinguished speakers here today. They really are. And Ed White, who will be our first speaker, is my partner at Nelson Mullins and the other co-chair of our healthcare group. He's going to tell you what value-based enterprises actually are, their regulatory advantages, and how they can help the integration process. Ed will be followed by Jonah Brulette, who's right here to the right of me, who is his principal and consulting actuary in the healthcare space of the well-known actuarial firm of Milliman. Jonah will discuss the total cost of care and some creative ideas as to how you can reduce those costs. We will then have Robert Ball, General Counsel and Chief Privacy Officer of Enlace Health. Enlace has an advanced value-based care platform that provides data analysis, network management, and value-based arrangement administration, which, among other things, is focused on helping to tie specialty care and primary care in a meaningful way. He will discuss practical solutions being employed today by payers, ACOs, and specialty providers, and illustrate how he believes that specialists and PCPs can be successfully integrated in healthcare, including by the use of a value-based enterprise. Our final panelist is Kelly Conroy. Final, but certainly important. She is a principal with Pinnacle Healthcare Consultant, a national healthcare consulting group. We've worked together, Kelly and I, for more than a decade on various projects, so I'm very well of her talents, which are extensive. She is a leader in the value-based care consulting space, and she's going to provide important perspectives from the view of ACO and primary care provider platforms. After that, we're going to hope to have a little bit of time to spend an important project of trying to move from our theories that we'll be telling you about to actuality in talking about how to use a value-based enterprise as part of a strategy to improve primary care and specialist profitability working together. And then if we have any time left, we'll take questions, but if we can't take them here, you can send them to us and we will respond. So, with that in mind, let me not waste any more time. Ed, tell us a little about value-based enterprises.
Thank you, Mike. Okay, let's get started. As a starting point, talk about this topic. For the most part today, specialists are still paid under service arrangements, and the integration of primary care into specialists is still a critical step as well as an opportunity in the development of value-based care programs. And I think the problem today, where we are today in primary care risk arrangements, the primary care physicians only manage a small portion of the total cost of care. And when they make referrals to specialists, they oftentimes don't get much information back, and it may not be very timely. And primary care physicians are also concerned about attribution and not losing attribution. And, the examples in nephrology, when the referral goes to nephrologists, the attribution goes to the specialist as well. And most arrangements today, the specialists are invited to participate with the primary care risk arrangement by providing a discount on their fee-for-service rates, and theoretically in return for some volume increases. And the volumes are not really meaningful to specialists, in terms of what they're getting, and if there's no conditions attached to their services, then they're really not motivated to do anything to bend the cost curve. And so there's sort of this mismatch in the way the two providers are being compensated. If you look at this chart, we're going to talk a little bit about the strategy today on this panel, and we have a model with a value-based enterprise that's in the center box, and that is being formed by the entity above it. In this example, it's an ACO or a primary care group that has some sort of risk arrangement, capitated payments, and below the value-based enterprise, we've got specialists on the one hand and primary care on the other, and they're providing services in conjunction with the value-based enterprise oversight and management, and they're plugging in through participation agreements, much like an ACO would do. And beneath that, the value-based enterprise is basically administering this care management plan. We'll talk about it a little bit in a minute. But when you get to the concept of the value-based enterprise, it's basically a vehicle. It can be contractual or it can be a separate legal entity. If you're going to do anything of any duration or scale, we recommend just setting up a separate LLC with its own board to administer it. And it's basically there to do care coordination functions and oversee those, or contracting for value-based payments, which again are payments where we're evolving, where the providers are working for incentives based on increasing quality and lowering costs, and eventually, arriving at what we call risk-based contracting. Now, this concept emerged of the value-based enterprise from New Stark and anti-kickback statute regulations that came into existence a couple years ago. And these regulations deal with the federal payment programs, principally the Medicare program. And the Stark law generally prohibits a physician from making referrals to an entity for certain types of services called designated health services if they have a financial relationship with that entity. And if the law applies, then they cannot make those referrals, and if they do, there are overpayments and penalties apply. But the bottom line is you have to find exceptions, and the statute has regulations that have exceptions. And then when you get to the anti-kickback statute, it's a little more amorphous, but it prohibits any sort of remuneration for referrals of these federal program patients. And it's also a criminal statute, in addition to having civil penalties. And it operates with safe harbors. And these are not exceptions, but safe harbors, if you can fit within the regulation of safe harbors, then basically the government has said they're not going to bother you with that transaction. But just because you're not in a safe harbor doesn't mean it's illegal or it's not permissible. Now, these regulations, you plug providers in through participation agreements. They're designed to accelerate the transition from fee-for-service payment mechanisms to value-based payment mechanisms. The rules and protection of these regulations protect compensation relationships. So if you're looking at ownership interests, you've got to analyze and deal with those under the classic Stark and classic anti-kickback statute provisions. But this is the first time that I can recall that CMS and the OIG collaborated to this degree to create these rules. They're designed to work in tandem, and they're very similar, but there are some differences. Now, to get the available protections of these new rules, the providers have to be working on one of four value-based purposes. The first is care coordination. The second is improving quality. The third is reducing healthcare costs to payers without reducing quality. And the fourth is transitioning providers from fee-for-service to value-based payments. And when you look at the value-based enterprise, I like to think of it as the hub. It's sort of an intermediate entity that's either managing care coordination or contracting and managing downstream risk downstream risk with the providers. And the requirements for a value-based enterprise, you have to have two or more participants. They have to be working on at least one value-based purpose, and they have to be working on a value-based activity. And there's nothing prescribed here. These are basically protocols and processes that are designed to increase quality and lower costs or transition providers to value-based payments. There's complete flexibility here, and I like to call the value-based enterprise the party's own innovation center. And it's notable that under the care coordination provisions, a referral can be a permissible activity, and that's just totally impermissible under the classic Stark. The value-based enterprise has to have a governing body, and it documents its value-based purposes, its value-based activities, and the benchmarks and measures and the progress that are being made towards those benchmarks and measures. And you have to define the target patient population. You have to do that. There's no attribution like in ACOs. You get to create and define the target patients you're going to be seeking to provide services to, and that's where the realm of the protections go. So it's very important to define that target patient population in the beginning. I like to think of these regulations as creating three models. The first would be care coordination, sort of the beginning step. The second is partial risk, sort of an intermediate model. And the third is full risk, sort of an advanced model. Now, you get the full protections of these regulations once you get to partial risk. You never have to totally move to full risk. And basically, you're probably going to be in one version of these. You can be in one or more versions of these all the time. For partial risk to apply, it can be as little as a 10% reduction in the provider's compensation, failure to meet benchmarks, withholds, et cetera, which is not much different than the typical pay-for-performance arrangements out there today. Now, the key distinctions between these rules and the classic rules, you're basically operating an environment where you're reducing compliance risk to allow you to migrate towards value-based payments. There's no fair market value requirement. There's no prohibition on compensation varying with the volume of value referrals. And if you meet the definition of a group practice within the Stark regulations, then payments can be made to providers in that group practice that are operating with a value-based enterprise in direct relation to their referrals of these designated health services, which the classic Stark rules would completely prohibit. You can disproportionately subsidize the startup cost and care coordination, the infrastructure, the support services, technology, care management workers, et cetera, through the value-based enterprise. And you can restrict referrals so that if one provider in there is making a referral, they have to first refer within that network of providers. And there's two exceptions: patient choice or the medical needs of the patient. I personally like the fact when you're in a value-based enterprise and the care coordination steps of documenting your activities and your purposes and your protocols, et cetera, it overlaps very nicely with clinical integration standards for federal antitrust contracting purposes, and it basically means you can be simultaneously creating a clinical integration network as you're working on your value-based enterprise, and it allows the contracting of independent providers through the value-based enterprise. And I think we believe the most important aspect of these regulations is if you're properly operated in a value-based enterprise, you're creating a low-risk regulatory environment for the anti-kickback statute. And to do this, you have to comply with Stark. Your activities need to be conducted through the value-based enterprise. You have to be accomplishing a value-based purpose. And if you're doing these things, you're actually mitigating anti-kickback statute risk, even if you're not in those safe harbors. And so that's what we refer to about creating a low-risk environment. And so if you look back at the slide here, the problem is we have this mismatch of compensation between the primary care providers and the specialists. And so the strategy or solution we'll be talking about today is basically using this value-based enterprise and have the primary care risk arrangement embrace the attribution and entering into the capitated arrangements. The value-based enterprise would contract with high-quality specialists, and then the primary care physicians would steer patients to those specialists. And then the value-based enterprise would be conducting this care management plan. Virtually would involve virtual consults between the specialists and the primary care, and there'd be creation of protocols for referrals and transition of patients, keeping more of the diagnosis type work at the primary care level and only moving to the specialist when it's absolutely needed. Protocols to overall improve quality and lower costs of both the primary care and the specialist services. And the care management plan would involve the arrangement paying the specialists for their work in the diagnosis and the care management phase. That can start with shared savings and eventually migrate towards partial or full risk based on procedures or total cost of care. And then the fifth thing the value-based enterprise would be doing is aggregating providers, primary care, because specialists need a lot of primary care lives to be effective at lowering total cost of care. But you're also creating a match, an alignment financially between the providers, the specialists, and the primary care. And the end result is, rather than a disjointed and slow process between primary care and specialists, you're creating an integrated process with earlier diagnoses, you're improving outcomes, you're improving access, and you're creating greater opportunities to lower the total cost of care.
Thank you, Ed. Ed, let me ask you, I'm on Medicare, and I tell you right now that a lot of times, and I'm sure this is normal, I don't call my primary care doctor. If I have a problem with my throat, I call up the ENT doctor immediately. Skip primary care doctor. How is this going to work in terms of generating a relationship when average person like me is allowed to and often just calls their specialist immediately?
Well, I think that would be part of the care management plan, the creation of protocols and steps to deal with those population of patients like you, Mike, that don't follow the proper
Don't do it the way you want me to.
We would have a protocol that would say you go to your primary care physician first, and they'll let you know when to go to your specialist.
Well, a specialist could tell me, I'm sorry, you have to talk to your primary care doctor first.
Well, your specialist, these are going to be a discrete group of specialists involved in here. They're going to be the high quality. So, these are the type of things, and again, you got complete flexibility to create the protocols, create the processes, and to develop steps to deal with people like Mike that don't follow the rules.
You know, I know who the high-quality specialists are. I go to them. Okay. Thanks, Ed. Jonah, why don't you describe us what the financial data tells you about value-based care?
Yeah.
You need a different slide?
Yes. So the way I'm going to structure my discussion is around sort of the status quo, what we're seeing right now within the value-based care space. What we've seen right now, and I think what we'll continue to see, is an abundance of total cost of care population-based model. When you have a total cost of care population-based model, the advantage there is that you're capturing a large proportion of total cost of care, which is what we want to do. That's the goal, to capture total cost of care in an arrangement that is a large volume of total cost of care that's at risk, so that we're not purely on a fee-for-service basis. Specialist carve-out models will continue to exist, and I think we'll continue to have them, but I think it's very unlikely that we will proceed forward in a post fee-for-service world with models that are pure carve-outs, all pieced together to get up to total cost of care. There's too much that falls in between the gaps there, and it's harder to get volume. To accumulate volume, it's harder to define a lot of those models. So what makes a lot more sense, and has been the approach of CMMI and Medicare, has been to identify a quarterback, someone that can hold that total cost of care risk. How that's been defined right now is primarily primary care doctors. So right now they're attributing the lives that are being attributed. You may have heard this. Not all patients you're treated are attributed. The patient's going to attribute to a particular doc, and how that's been defined in the current system is that's going to be based on primary care evaluation and management services. So in Mike's example, the primary care doctor that he skipped over is probably still attributed him based on some amount of care that he's receiving there. And that's within the whole system. And so what we've seen right now is a large amount of amalgamation of risk by primary care entities or entities aggregating primary care entities to take on that total cost of care risk and find ways to generate value on that. There's a large number of lives that you can generate value on, and there are various ways to generate savings on that. What we've seen to date, I think, has been driven, a lot of the savings we've been seeing to date are driven, at least in part, by favorable selection of lives, since these programs are not mandatory. We are not covering the full spectrum of patients. So favorable selection, and driven by risk score optimization, as Medicare fee-for-service risk score capture has been historically quite low, quite inefficient. So there's been a lot of initial savings garnered from taking risk for these lives, aggregating these lives through the primary care doctors, and then making sure their risk scores are coded properly, and making sure that they're actually not not receiving any too complex patients. So that's kind of been the initial phase. I think as agreements renew, when agreements renew, past improvements in risk score don't pay out as much as they did in the initial phase. Past selection bias doesn't pay out as much as it did in the previous phase. It's built into the benchmark. Everyone's aware of sort of the race to the bottom. I think that's a problem. In my second panel, I think we might discuss that a little bit more. But at least the first phase of that, I think, is intended in that there will be, here's the initial phase of savings you've gotten. Now you're going to have to do something different once we renew agreements. That's the reason these agreements renew. That's the reason that benchmarks are reevaluated over time, right? And as they do that, I think we'll hit up against this issue that I think a value-based entity will be a requirement for success in the programs. If you want to continue to generate savings on an increasingly lower benchmark that already has proper risk score put into it and already reflects the risk, the selection of lives that you're taking risk for, you're going to need to actually start bending the cost curve. And PCPs do not directly, as illustrated by our great example, do not directly manage every aspect of that total cost of care, and this graph is great. When we're talking about managing total cost of care within Medicare, we're really talking about managing a relatively small number of very high cost patients. They're not the same every year. There's in and out. There are some that are the same. And who is most responsible for managing those costs within a year? Probably not entirely, or maybe even majorly, the PCP. It's a specialist. It's an episode of care that needs to be managed appropriately. And so that's going to demand that primary care doctors have a more, if they're going to continue to take large downside and upside risk for these very large number of lives, they're going to need to have more certainty that they can control the overall total cost of care. And right now, we do not see that primary care docs do not directly control a high percentage of that cost. Most of the cost that arises within a given year is probably managed by various specialists throughout the year. So finding a way to involve specialists and develop an actual integrated care model will be essential if, as I suspect, we're still going to be seeing large numbers of patients aggregated to the primary care doc as a mechanism to get those people at risk. I think we might have one more slide, but I might have.
I'm gonna let you have it too.
This is just a nice graph we've done as we've delved into what specialists might be managing up to 80% of total cost of care, right? It's very diversified, so that diversification creates a difficulty in giving the risk directly to specialists, and many patients would appear on multiple lines here. So if we're gonna have this primary care entity take the risk for the patient, they're going to then need to be quarterbacking the management throughout all these various episodes, identifying which ones are most important and where they need to be managing those cares, and they need a mechanism by which to do that. And I think that's what we think the value-based care entity is.
Thank you very much, Jonah. Very, very helpful. Good in having an actuary on our program here. The next person I'd like to ask to talk is Robert Ball. Robert, could you explain how Enlace, your company, envisions a solution to these issues?
Certainly. We, as you said in the introduction, we operate a value-based care platform that really starts with analytics and moves all the way forward to contract management, network arrangement, and the full scope of the solution there. And I think that where we see things fitting in, I'm going to echo points that Jonah and Ed made, but again, what Jonah, just to drive home what Jonah just said, that the PCP is holding the risk. So they're allocated all the risk, and they're the quarterback. And then on your other slide, it said, they don't know how to manage the risk. And again, sort of the shtick is up with the risk scores, et cetera, that game's come into a very, abrupt end. So if I'm trying to look at this most expensive 20% that's on me, and 80% of that spend is of the overall spend is in specialty, then really the only way to bend the cost curve going forward, or not the only way, but better be one of the ways you're looking at, is to figure out how to get this interaction between specialists and primary care. We have, how are you going to bend this cost curve? The only way is to drive these relationships and get away from fee-for-service. And again, right now, nothing's aligned. The way they're managing most all the relationships with specialists is not via value-based arrangements, it's via discounts on fee-for-service, and again, putting a Band-Aid, some of the stuff that Jason was saying, just putting a Band-Aid on what's been there before. And then you have to educate the specialists to look at the whole of the specialty care, not just, if I'm doing a knee replacement, I'm just not doing the knee replacement. I have to first take somebody, when Mike calls me directly, instead of going to his PCP, I got to work. And so let's get some efficiencies in the diagnosis phase, like you were talking about, Ed, to where how much of that can you offload to the primary care so that the specialist who really just wants to cut is not having to deal with the diagnosis phase as well. That's a way to bend the cost curve down. Not to mention the satisfaction, the patient satisfaction, when I do go to the primary care and say my knee's hurting, they say, well, let me refer you to a specialist, and 6 or 8 weeks later, I'm able to get an appointment with that specialist. So the value-based enterprise and the value-based arrangements, allows these arrangements to come together, focus on outcome, focus on quality, and drive the cost down. As Ed pointed out, and is in the blog post, what can you do with these value-based enterprises that you couldn't do before or had restrictions under Stark or anti-kickback? It allows the steerage. It motivates the primary care and the specialist to work together on care coordination. And it also allows, part of the issue you run into is if I'm a specialty practice and a particular ACO comes to me and wants to do a value-based arrangement, that may sound interesting, but there's not really enough lives or instances for my practice to do something. So if you can aggregate in a value-based enterprise, the ability to kind of flip the model to where a orthopedic practice can have access to a number of primary care practices, then you're aggregating enough demand to make it worth their while. And then you put in place arrangements that motivate, incentivize, whatever word you want to use, the activity that you want the specialist to be thinking about, either if it's site of service shift, getting them out of a hospital to a surgery center, major way you can cut the cost, and dramatic in the right instances. And then again, using the processes and control of the value-based enterprise to be able to facilitate this and do it by contract instead of having to have full-on acquisition of a practice or something of that nature. Again, we've got the PCP as the quarterback, as you said, Jonah, and imagine being the quarterback, and I'm responsible for what the quarterback has to do, but I have no control over what the receivers, the linemen, or anything else are doing. So it's on me, but I have no control as to how to make that happen, because 80% of what's going to happen is not me running down the field or throwing the ball. It's the 80% is somebody catching it, somebody blocking, somebody it's got to be coordinated. I'll probably, let me save some time, because after we kind of finish, I'll give what have we done, sort of a realistic sort of example of how we're putting this in place, to your point of taking it from theory down to practice. But I'll defer to Kelly from here.
Okay, thank you, Robert. Kelly? What can you tell us, give us some perspectives about all of this? You're very good at that.
Okay, thank you. Thank you for inviting me every year to innovate, because I think VBE came out, 2.5 years ago? And not a lot of people in the country even know what it is. And one of the reasons I think people don't know is because, is it an ACO, is it an APM, is it a what, the acronym soup. But when you really understand what a VBE is, it's this beautiful regulatory umbrella that the government has said, we're going to let you start referring to your friends, referring to who you know is good, high caliber network. We're going to let you do all this stuff, and we're going to protect you from the laws that we put in place in the past. But you need to embrace it and start creating these things with the stakeholders that we haven't done before, like the specialists. So I wanted to say that the first decade, we did do a good job putting the primary care in charge of this, but they've also added so many programs in the last few years that they've siloed the specialist off from the primary cares. So they created the nephrology one, they created GUIDE, they created all these different things. And the specialists are just out there doing whatever they can. They're not even really motivated by the ACO anymore. And I think the ACO REACH hurt us a lot by coming out, and everybody that had an ACO REACH went to a specialist and said, give me 5 or 10% off of your fee and we'll send all of our business to you. Well, one, that's terrible. Two, you can't control the referrals in an ACO. So that didn't work either. So it's time for the specialists to step up. They absolutely have to step up and figure out ways to innovate with the primary care. There's a driving urgency, as I see it, because so many people are getting hit with cuts, right? The Medicare fee schedule just came out, so lots of people took a hit. Independent diagnostic testing facilities took a hit, a big hit, between 1% and 9%. They would be the perfect people to talk to about a value-based care entity. Come join the ACO, come get close with us, and let's make this happen so we reduce wasteful spending and things like that. So also, Part B cost for ACOs and anybody that's doing some sort of population health business has increased. When we first started this in 2012, the Part B and the Part A costs were about the same. Lanny, I'm looking at you, but surprisingly, the Part B has gone way up and the Part A has gone down, which is what we worked on, right? But it's not escaped CMS that this was a big problem. So, and then of course you heard Jason tell you about 2030, everybody's going to be in an ACO or tied to some sort of cost and quality. Well, another reason that it's important is, I didn't hear anybody mention this today, but I think it's really important. We used to talk about the silver wave, about the baby boomers coming in, and we used to say 10,000 baby boomers are coming in every day. Well, it's now up to 11,400. This is the peak year. All baby boomers, I'm in that group, believe it or not, and all baby boomers will be in by 2029. So it's not coincidence by 2030 they want this all tied up. So I see that writing on the wall with the silver wall. That's an additional 4 million patients into the system already. So everybody needs to get more efficient. Specialists need to stop seeing patients for primary care things, and primary care really need to do the work and coordinate the care.
Kelly, isn't it more, it's more than just everybody ought to do it. Fact is, the CMS is telling you.
That's
you
right.
have to do it.
So if you go to the next slide, I wanted to show you that when CMS puts something in writing, when they put their roadmap in writing, and Jason, I really appreciated your keynote this morning. When they put it in writing, they've been thinking about it for 10 years. So this is what recently came out from the Innovation Center on specialty strategy goals. So you can see here, number one is they know they have to give some data. Like, you can't manage to what you can't see, and the ACOs aren't really good about giving the specialists the data either. Like everybody, it's metadata. Everybody's just trying to figure out what is the priority, where should I work first. So they're going to give data transparency, and it's already started. Already ACOs are receiving shadow bundled episodes. So basically it's different disease states, and it's telling you a whole bunch of things about it. So if you're an ACO and you want to tackle a certain disease state, neurology or ortho or cardiology, you have a lot more information than you ever had before. They also want to maintain these episode payment models. I think they're testing them, and that's We already see that happening with the BPCI Advanced Guide and all these other things. I do believe that's somewhat of a problem because attribution, the PCP gets the attribution and they keep trying to test these other models like the CKD model or the CKCC model. And now what we have is primary care and nephrologists kind of fighting over the same patient, and the patient moves from one program to another, so that's not helpful. And then 3 and 4, they're going to create incentives for primary care to engage specialists, and then they're going to create more financial. So it's coming, like Part B costs are going out, so it's absolutely coming. And if you're sitting in the audience and you don't have a strategy for specialist, or you're somebody that's with a stakeholder that has a specialist, you really need to be thinking about it, because once they've put it down, you need to be one step ahead. And the other reason I'm really thinking you need to know the rules, and I know there's a lot that come out, but if you don't know the rules and you make a decision, like you don't know version 24 and version 28 had a big impact, you're going to just get, it's going to hit you financially. So you just have to really kind of read through these rules and understand what's coming your way and make your strategy, because it's coming and there's so much more. Like, if anybody read the Medicare fee schedule that just dropped on November 1st, you can see they're going to pay for so many programs. And if you look at those programs, they're all Band-Aid ways of trying to get the specialists in primary to talk. They're going to pay caregivers. They're going to give advanced primary care incentives. It's unbelievable how much is in writing already, and it came fast. Like at Pinnacle, we've been talking about BBEs for 2.5 years, and overnight, many of our clients, we do co-management agreements. Overnight, those co-management agreements, once everybody starts realizing the specialists are getting squeezed, we need to find another way to plug into value-based care. So our co-management agreements, we're talking about BBEs. And maybe I'll just pause 1 second, Mike, and then I'll let you take it away. But I want to make VBEs really simple for everybody. So Ed and the lawyers are probably going to kill me in the room because it is not simple. I get it. I know it's really hard. But it could be this simple. You could take an ACO or a CIN that you already have set up and you're already operating, and it already has its board. And many people that have both do like their board meeting on the same. So you can take the same governance if you wanted to. You can overlay a VBE on it, and I think it meets most of those things that Ed, you'd have to have a lawyer help you with this, of course, but it meets most of those criteria you have to make so that you get all that regulatory coverage. So I think a VBE is the chassis, and I do think that CMS in the very early days said, listen, this is only going to work if you work with all stakeholders. So I think this is the door to open up to work with any stakeholder. And I'll just give you one more example. I'll wait. Maybe
No,
you
you
have
go.
questions.
You're on a roll.
Okay. Let's see. I did have some examples. So co-management agreements, neuro, ortho, PCPs in an ambulatory surgery center. Has anybody ever heard of that? I mean, remember the day it's the specialist, it's driven, but if you brought the PCP in and the ambulatory surgery center came in under the ACO, you can refer to the ambulatory surgery center. Talk about site of care savings, right? If it's safe, you can refer. You can create that pathway. I remember very early on, the doctor said to me, man, if we could refer to our friends and the people we know are good, we could fix this problem. And Stark and anti-kickback prevented that in a lot of ways. So they kind of went to their own corner. So I think that's going to remove that, which would be really nice. And I guess that's all I was going to say. I know you
Very,
have other
very
questions.
good. I knew we needed you on this panel. Okay, we do have time now to go through this. We've been talking about a lot of theory. We wanted to basically set up a potential situation of where we could talk about how we might be able to use what we've been talking about to help the situation. So here it is. I'm going to give you, this is just a sample. We could have a million scenarios. This is just the one we picked, in which you have a client, and your client is an ACO or a large primary care group or a primary care-driven CIN who is very frustrated with declining revenues. And they're hearing about the CMS payment reductions, and they are, or maybe they're experiencing them, and they want to do something proactively to counter the tide. What do? You're familiar with this strategy of integrating specialists and primary care physicians with a value-based enterprise to contract together. What do they need to do to get started? What steps should they take to see if this strategy can work for them? That's what we're going to focus on. How do they get started, and what strategies can they use? So who would like to go first? Go ahead.
I'll jump in. I'll tell you what we would do. Not a sales pitch, but this is what we do. So we live in this realm every day. We have, as I indicated, we have a platform, an analytics platform, and we have tech-enabled services for the contracting side. And we also have set up, with the help of Ed and Mike, an independent VBE. So if you don't want to go through the whole corporate strategy of setting one up, if that's too big, we've got one ready-made that you can contract with and be able to leverage all the benefits of the VBE by contract and not have to go through that, which a couple systems we're working with, they're like, man, if I have to go tell my general counsel we're going to set up another subsidiary that's a VBE, that's a whole thing. So we've got that ready-made, ready to go. I mean, what we do when we walk in is, first we try and understand where the ACO is, where the group we're talking to are on their sort of their VBE, VBC journey. And quite often, you know, they're working with somebody like Kelly with Pinnacle, or they're analyzing the data with folks like Jonah, so they're in there. So this all, it's not a one-size-fits-all. We don't have a silver bullet that satisfies everything, or they're working with Jason and the folks at Helgerson. So they come in there, and the first thing we do is we walk in and we say, okay, let us analyze your historical claims data that you have. Give us 3 years of your data, and let us go through and take that data in and analyze, and we will be able to look at your specialty spend historically, score it, provide insights into it, and then start to look at how you can start to, you know, what specialists are you working with? Is your best buddy who you want to send things to really the best quality and the best price? What's happening? So giving insights to the ACO as to what's happening in their data. We can then score that data and come back and say, here are your best-in-class specialists, and here are your opportunities where you can use bundles, episodes of care, other value-based arrangements to bring that in. And they can start off as care coordination. They can be retrospective. We manage probably the largest retrospective program with a regional payer in the country. We've done prospective deals where there's downside risk, partial and full. And again, you always come back with the challenge. One of the big orthopedic practices we work with, which is a multi-state orthopedic practice, said, you know, reason we can't, kind of back to Jason's point about specialists who want to be in the value-based arrangements but are hesitant to do so, is they don't have access to data. This very sophisticated practice was sitting there saying, well, we'll take some downside risk, but then the way they went about having to pay the facility and the PT and the anesthesia once they took it on, they literally cut manual checks and ran it on an Excel spreadsheet because they didn't have the operational capabilities to pull it off. And the payers weren't really sharing with them the data, so they had to go to the patients and say, can you share with me how much, can you give me some of your bills and see, you know, what you got from the payer on this? What were your allowed rates and what were your reimbursement? So we can come in and score that. And then we can, now we've got the data platform, you can constantly update that. You've identified the opportunities you go after. And then we have a network services team that's very skilled in coming in and saying, okay, what sort of arrangements do you need to put in place? Because as you heard from everybody here, not one size fits all. So, and typically we highly recommend a crawl, walk, run. Let's start with some incentives. And you have to convince the ACO, you know, take a little bit of what you're going to save here and share it back with the specialist is one of the points that we brought out. You've got to motivate, and you've got to set up arrangements that will motivate the specialist to take the type of behavior you want here. And I'm telling you, it's possible. I've seen it in retrospective deals, prospective deals, and some of the savings are pretty enormous. And then, you know, then again, we just become an advisor, probably usually along with others who are helping through this crawl, walk, run to get into and start to leverage the VPE to drive these real savings, and we've seen it.
Thanks, Robert. That's very good information. Anybody else got anything to add to this ideas?
Can I ask a question?
Sure.
If it's not difficult to answer, what's your source of data that you're using to show everybody what their position should be, how they're performing?
Well, you go to an ACO and you say, give us 3 years of your historical claims data, all of it, and we'll intake it, and then we'll basically reason over it and come back and say, here's where your specialty care spend is. Because there's a load of that data, but the ACO doesn't have the skill or the knowledge, most of them, to understand where the specialty spend was, and they've never looked at it. They know they have the spend, and because they've got the arrangements with the specialist, and they know that the cost went out, and it's either them or the payer if they're being paid, the ACO's being paid upstream. But you can get that claims data and then reason over it and come back and say, here's where your specialty spend is, in terms of which specialties, in terms of which specialist, by area, by procedure, and you can really start to, it's amazing what it reveals in terms of, what is the cost of an implant across these 12 orthopedic providers, and it's all over the board. So I'm sitting there as the ACO, and I've got to manage that cost, and I'm dealing with these, and even within a big orthopedic practice, that might be all over the board. So how do you start to look for efficiencies? Skilled nursing, anesthesia, again, site of service, how many are, a lot of times, if I'm getting paid $3,200 to do your knee replacement, and I live across the street from the hospital, and it's convenient, I'll just do it at the hospital. It's no skin off my back. I could move that to a surgery center, because it's a 55-year-old marathon runner, and cut that cost dramatically by moving it to a surgery center. But, so what's my motivation as a specialist to do that if I'm just going to get my fee for service to same cost, whether it's done here or there? And, the implant, I'm not paying for the implant, right? So I'm going to probably get the implant from whoever gave me the best golf outing or his best friend, that we all know that game. So those are the sorts of areas where you can start to really dig in on this.
I'll also add to that, that Medicare 100% data is now pretty readily available. So within Medicare, whether it be Medicare Advantage, fee-for-service, or even Medicaid data, a lot of that is now generally available through sort of a CMS portal, and can be leveraged to look at what it's really used for, benchmarking performance nationwide, so outside of the ACO, also validating things you're seeing within the ACO. But yeah, I think that along with ACO data, and then on the commercial side, we're generally still using broader collected data sets that we're all familiar with, and looking to that to price and benchmark, and then piecing together what we have available from the payer.
Yeah, and to be clear, we've been primarily in the commercial space, working with a lot of payers who have the data, so that's a good point.
Yes.
Ed, you got any?
No,
Kelly?
I see a question, and I think the audience should
Oh.
ask a question.
I have two questions. As a follow-up to what he was saying, can you say percentage-wise how much revenue can you increase to a practice or a healthcare system based off of participating in these programs?
You can set targets, and,
I'm talking about in terms of additional revenue you generate based off of.
I can give you kind of broad strokes, sure. For a regional health plan that we've worked with across, they generated 20-some million in savings off of their primary care value-based enterprise aspect, their plan there, across around 400,000 members. Across about 7,000 episodes using primarily an ortho, but also some maternity and some gastro, we helped generate for them over 20 million in savings.
And they got a percentage of that savings.
Yeah, the way we, again, we have different arrangements with what we do. Well, that accrued, that was the savings that accrued to the plan. And part of that, they did share back with the practices to motivate them. Or in that case, there were some prospective arrangements where they literally were saying to a practice, let's get a fixed price for a knee replacement in this area within this group. And based on that, then the practices were managing downstream the savings that accrued up to the plan.
And it benefited the specialist because the primaries knew that we need to send it to practice A because that's.
Well, in that case, it was mainly the plan pushing it directly with the specialists. There wasn't a whole lot of PCP specialist integration in that.
Ed, you have any comments about all of this?
Well, I do, and I also want to ask a question of some of the other panelists here, but I think, if somebody comes to us as lawyers, they start with us, or talking, we'll obviously can lay out the corporate strategy, the regulatory strategy, and the steps. And I think it depends on the sophistication of the client. Some of them have a lot of experience and depth in their own organizations and familiarity, depending on geographically where they're located, as far as, value-based contracting or stepping into risk-based contracts. And so that's sort of a first step, sort of gauge, and whether they need to talk to somebody like a Jonah or a Robert or a Kelly. But then the other piece is what we tell people, and it's really the point of this whole model of aggregating enough, I think you'll have a significant number of specialists you need, or patient lives, to make it meaningful for specialists to move the needle, that you don't have to dive into a full-blown, mature, value-based enterprise model, but you could just start one step at a time, and if you start with one primary care arrangement or ACO or platform group, and you target specialists, and then you aggregate and grow and you evolve, and you could turn into, something similar to like a super SIN, but you're trying to get those lives. And I think I'd be interested in hearing from Kelly and Jonah, but, what if from the ACO's perspective, Kelly, I know you work with a lot of ACOs, how do you think this kind of model would be received when, if you're sharing this with them? I mean, I know there's some trepidation of ACOs sharing their shared savings. And you said before, if they negotiate a 5% discount from specialists, that all drops to the bottom line of the ACO. But if it's going to get harder to generate shared savings, they got to find new methods. And so part of that step is investing and getting higher returns out of the specialists. I think
they're ready, Ed. I think they're ready. I think the first year they didn't want to share their savings. It was very difficult to give specialists. I started an ACO, Palm Beach ACO started with specialists. They still have specialists, but that is not the model we see around the country. Mostly it's primary care. But I think they're ready. The Part B, like I said, the Part B cost is now higher than the Part A. They've done all their work on that, so they know they have to tackle Part B. And how do you tackle it without a vehicle like this that can align the incentives properly? So I think they're ready. I think they're ready to start sharing, because they're not going to have savings either if the Part B keeps going up. And there's just so much momentum and so many programs that are coming out. They have to figure out next decade stuff to do, which is, kind of like already laid out for us. So I think they're ready. I really do. What do you think, Jonah?
I think they're ready as well. And I think a key piece of this is, as far along as we are, downside risk is relatively new. And I think a big motivator for wanting to share the savings, of course, you don't want to have to share the savings if you can hold it onto it. But I think the other piece of that, the other side of that, is the downside risk. And to mitigate the downside risk appropriately, I think they need to feel like they have some control over these specialist episodes of care that are arising. And so as the benchmark tightens down to an area and buffer isn't available in risk adjustment or patient selection, the low-hanging fruit, there becomes a motivation to target lesser savings but more guaranteed savings. And I think by engaging specialists, you achieve that goal. So I think it hasn't necessarily been there, but I think it is growing, because that is for PCP, that's the primary way to mitigate risk from a total cost of care, is engage people who can actually manage it.
And there are ways to do this, again, sort of in a crawl, walk, run, where you go in and you don't go full-on risk day one, to your point. It's, let's do some shared savings. If you do X, Y, and Z and we get savings, and on a retrospective basis, we'll share some of that savings. So there's really not a lot of risk there, but we're coordinating a little bit. And even if you start to do some prospective downside risk, you can cap that downside risk and backstop it with stop loss and other ways to do it. So, and you have to be really careful, but you can get all the way to where I'm going to take episodic. If I'm a orthopedic group, I'll take episodic risk for this population, and we'll go all in. But I think that's down the road.
Yes, sir.
I'm listening to all of this, and you're talking about controlling costs and everything else. one of the things that I think is missing, and I'd like your opinions on this, is how are we going to actually truly bend the cost curve by getting rid of the medically unnecessary and the medically inappropriate activities that go on within healthcare? And I'm just gonna be blunt here. PCPs are the worst offenders when it comes to ordering diagnostic services, whether it's pathology, radiology, or anything else, because they don't truly understand those particular service lines. They think they do, but they don't. And so how are we, if we're going to have the PCPs as the gatekeeper, them the biggest culprits in misordering of diagnostic services, how are we going to get them engaged to actually appropriately order diagnostic services? Because that's going to decrease the cost of care dramatically.
Hey, Mike, can you put my slide back up there? Mike,
Harvey?
put my slide back up there.
Sure.
I want to address your question with that, if I can, or let the panel jump in here. But so the concept of the value-based enterprise, that value-based enterprise, and whether, Kelly, it can overlay on an ACO, it can be independent of the ACO, that all works very well. But it really goes to those protocols and processes you develop and design, and there's no written rules. You get to create it all. So it goes to the caliber of the people you put in the management process. The groups are plugging in to participate in that, and obviously you may have some representatives in the groups there, but you evolve and create those processes yourself to manage down and the collaboration and the consults with the specialists to identify what's really needed and what's not needed. And so you get to do it all yourself. And it ultimately comes back to, y'all weigh in, but I think the quality of the representatives and the people that are overseeing those activities. And it's, another thing I would suggest about this is when you think about scale and it's really going for the long haul, you invest in putting people there and paying them in time to make decisions and think through things and study things. And it's not just busy professionals that are doing this when they got a moment. It's not the providers themselves necessarily. You may have some that go up there, but it's like all of us have busy lives, but you get somebody at that level to manage. Y'all have any thoughts on that?
I have one thought. The PCPs are in charge because that's the way the program was set up. So, and we spent the last 1 year decade, but having the PCPs elevated, right? So you're right, the second part of that didn't happen, which was to bring the specialist in, right? So we actually made it worse between specialists and primaries, if you can imagine. So if the PCPs do not take control of this movement in this decade, it's going to get taken away from them, I think. That's what I think. And so all that roadmap I showed you with all the stuff coming for specialists, they're giving out report cards now for specialists. I mean, it's going to come, but it's coming to the ACOs first, and then it'll come out to the public, like URs. Remember in the old days, every doctor could get their report card on how they did, and it looks not good on paper, but you don't know they're measuring it. Of course it doesn't look good paper. So I think if the PCPs don't step up, it's going to be subcapitation. Jonah likes to talk about that, right?
I'm listening to this, I'm recalling those old FTC about antitrust. Remember all those old things? Norman, Oklahoma, and all that. I should go back and read those, because the truth is, a lot of what we're talking about was set up right in those things.
That's right.
Which
That's
is
the
like,
point.
the latest one was 2012. They're way back. But very interesting stuff.
Yeah, I'll just add, I think in the initial phase of this, as Kelly pointed out, PCBs might have been a little more isolated because they got to hold all the risk. I think as benchmarks come down, the pressure emerges for them to change their own practices and appropriately involve additional players in the healthcare space. I'm not sure that pressure has been there in the initial phase as we're learning, as there has been low-hanging fruit, things that needed to happen to start off with. But I think over time, as it doesn't have to be a race to the bottom purely, but as that concept starts to influence these agreements over time, I think that pressure will emerge.
Well, this has been a lot of fun, but we got to go on to panel 2. So thank you very much.